research chapters are about 50 pages long, and half of the time you can't tell what is important. This video will help you to see it all fast. If you are a nursing student, this could save you hours of rereading. And if you are here just to better understand the conditions, I hope this makes the topic feels less intimidating. Hi friends, and welcome back to my channel. I'm Nurse Mia, and this is part 2 from the Med-Surg RN chapter, the outline from the GetZen RN study group series. Before we get into the details, I always like to zoom out first to look at the big picture of the chapter. I use a concept map like these to break it down heavy chapters so you can see the full path of disorders, lab intervention, all at a glance. You'll know exactly where to zoom in and what to prioritize. It takes the pressure off and makes the chapter easier to follow. Comment below which section of this chapter feels the most overwhelming for you. The goal? One page of clarity you can revisit in minutes. A map turns 60 pages in 10 minutes of review. Clean path, less noise. You will know where to start and what to skip. Let's get started. Chapter overview. The chapter is talking about the preoperative phase, begins when the decision for surgery is made and ends when the patient is transferred to the operating room. And this phase is critical for ensuring patient safety, minimizing complication, and preparing both the patient and their family for the procedure. Here is the concept map that I'm talking about, and this is the way the chapter is divided in 5 categories. Number 1 is talking about the informed consent, then the patient preparation, patient assessment, times out, pause for cause, and at the end of the chapter it's about nursing management. So each slide will be one of these structures. The chapter starts with an introduction to the operative phases. Explains a little bit about those 3 phases: the preoperative, intraoperative, and postoperative. This chapter 15, it's about preoperative. It's before the surgery. It's the key word. And this preoperative phase begins when decision for surgery is made and ends when patient is transferred to surgical site. The nurse's role is to be the educator, advocate, and admittance nurse. Main priority is completion of preoperative checklist. Will be a figure about that in the chapter more in detail. Ensures documentation, assessment, preparation, and education are complete, and also promotes patient safety and readiness. Components of the preoperative checklist, it's like a full medical history, including a prescription, over-the-counter, herbal, alternative therapies. Assessment of the patient's health status, collection of intra and post-operative care documentation, completion of pre-op orders like IV, antibiotics, dead horse, etc. Patient education on surgical process. Then also it's talking about verification of signs informed consent with witness, and initial timeout, pause for cause, which is like confirm ID information, name of surgeon, procedure details, correct surgical site if it's unilateral. Then it very briefly also talks about the intraoperative, which is during the surgery in the operating room, and also it talks a little bit about the post-operative, is the recovery phase. So intraoperative it's in the next chapter 16, and the post-operative it's chapter 17. The part 2, it's informed consent. I divided here in the more other steps, which is components of the informed consent, advanced directive, obtaining informed consent, the role of the surgeon, the role of the preoperative nurse. So in detail, let's talk about the definition, which is patient autonomous. So it's cognitive agreement to the surgery after weighing risk, benefits, and alternatives. The nurse role is not to obtain consent, it's provider's responsibility. So the surgeon on the cause. Ensure patient understanding, fill knowledge gaps, clarify info. Here, NCLEX likes to give a lot of questions. Advocate for patient comfort and autonomy means that the patient has to agree with it, and he is fully aware of what the surgery is and all the steps. The legal ethical key points here is patient has the right to refuse surgery, can change the mind. Another NCLEX questions, even if refusal risk of death. Components of the informed consent, it's a big figure in the book. It's figure 15.2. Consent for procedure must include name, type, reason for the surgery, the surgeon name, benefits of procedure, alternatives, consequences of no surgery. Then another component is consent for anesthesia, providing by anesthesiologist or the nurse anesthetist. Also includes type, medication, risk, administration method. Another component on the informed consent is consent for blood products. Another NCLEX questions, like people that have different religion might refuse certain to get blood product, might be part of surgical consent or separate. So the nurse's responsibility is to identify religion, cultural restriction. Also, patient might sign blood refusal form marked like no blood products in the chart. Another special consideration in consent is one, its inability to consent, must be cognitive impairment, medical power of attorney, physical disability but capable, can mark with the X signature with two witnesses, language deficits, in a hospital interpreter, like not family. Also minors has also this inability to consent. Minors legal guardian signs. It's a procedure explained to child if able to understand another. NCLEX questions here about minor. They can trick you if it's 16, if it's a right, it's a wrong. And emergency, also it's a special consideration consent in case of emergency. It's a verbal consent acceptable or written obtained later. Like here it might be another tricky question with patient comes with signs and symptoms of appendicitis and they need right now a surgery. Or if no surrogate, so these to provide a document emergent need. Another special consideration consent can be special procedure like sterilization requires unique consent signed 6 weeks before. The advanced directive, like you can see there in the my little step 2, is the Patient Self-Determination Act in 1991, is the patient right to plan care in emergencies. And type of it's like durable medical power of attorney, which is design decision maker, living will, specify choices for resuscitation, intubation, feeding tubes, long-term ventilation. DNR orders must be recorded in the chart. The nurse responsibility here is to note and attach advance directive, living will to the patient chart. Obtaining informed consent on 3, you can see there, obtaining informed consent responsibilities. So we have the surgeon, right? And so solely responsible for providing procedure information and obtaining consent. Must occur, of course, before sedation or anesthesia. Ensure patient family questions are all answered. Preoperative nurse is to clarify information that addresses misconceptions. Also to witness signature only the act of signing, not the content. Ensure consent form is placed in the chart, so must be attached into the chart. Also to document completion of consent process, all the documents. It's another box which it's in the chapter talks about why patients do not read consent forms. They are too long, too much info, intimidating, small print, medical or legal jargons. People they don't understand and they just try to say like, yeah, I understand. But preoperative nurse role is to clarify and make sure the patient is fully understanding about the new coming in of surgery. 3. Timeout, pause for cause. We have a figure in the chapter about it. It's a figure 3. So the purpose is to prevent the wrong patient, procedures, site error. This might be in quizzes and NCLEX. The process have few parts. Starts at admission with wristband reviewed with a patient. Patient verifies name, date of birth, procedure, site. Surgeon marks surgical site, but sometimes patient marks too. Repeated on transfer for surgical site, circulating nurse, immediately before incision enter entire team. The key safety note is to performing timeout immediately before incision minimizes irreversible errors. Components of the timeout is patient states full of name to match the ID band, at least one additional identifier. Patient confirms correct procedure, correct surgical site. Surgeon marks the surgical site. Final confirmation team performs before incision. Acceptable patient identifiers are name, date of birth, social security number, it says in the book. I don't know, I disagree here. Photo on band, address, telephone number, um, and the drive license. It's not in the book, but I think drive license would be better than social security number. This part is a little bit longer when it's collating the data about the patient assessment. And first you start with patient history, complex medical, social and surgical history is essential. Question might be sensitive, require reassurance and privacy. Nurse ensure accuracy, updates and documents in the preoperative record. Medical history identify conditions that increase perioperative risk, like CVT, which is the cerebral venous thrombosis, cardiac disease like arrhythmias, heart failure, diabetes, delayed healing, infection at risk. We have asthma, COPD, ventilation complication, immune deficiencies like poor wound healing, implants, prosthetics, dental work, positioning, intubation concerns, pacemaker, interference with electrocautery may require disabling with specialists present. Surgical and anesthesia history, it's past surgery like scar, implants, document type, year, reason, anesthesia type, healing response. Note any adverse reaction to anesthesia, if any. Allergies, document allergies type plus physical response, like on medication, foods, dyes, lactase. adhesives, environment. Patient wears alert bracelet. Latex allergy require latex-free in OR setup, early scheduling for that. And also the chapter provide like a big table about medication. Document all the prescription, OTC, over the counter, herbal and alternative medication, what for antihypertensive, anticoagulants, antiarrhythmics. Note potential interaction or bleeding at risk. Last, oral intake and PO status. Adults typical NPO is around 8 hours for solid, clear fluids up to 2 hours pre-op. Infant children guidelines, they have like solid for 8 hours, formula 6 hours, breast milk 4 hours, clear liquid 2 hours. Here it's a tricky questions about infant children between breast milk and formula. Formula 6 hours, breast milk 4 hours. Exceptions for the diabetics or essential medication with sips of water. Alcohol, smoking, drug use for smoke increase risk of respiratory depression, DVT, wound healing delays. For alcohol, drug use, alternate anesthesia response, complex pain management. So special consideration will be ask sensitive psychosocial questions, abuse, mental illness, gynecologic history, privately. Address also discrepancies between chart and patient response. And then number 2, we have physical assessment. Includes height, weight, vital signs, pain, and full system check right during that pre-op visit. Height, weight, which is guide anesthesia dosage for and fluids needs. And then consider OR equipment capacity, like for the VMI, bed, and table size. The vital signs, it's obtain a baseline, compare with the prior records, repeat if abnormal or alternate by anxiety. Fever may postpone surgery. Pain management, we use numeric, 0, no pain, and 10, the worst pain ever. Also the phases scales for pediatric, document acceptable pain score. System assessment, we have like cardiovascular, like pulse, blood pressure, murmurs, rain, peripheral pulses, color, trigger, cup refill, edema. For respiratory assessment, we have rate, depth, breathing, lung sounds, O2 sat, airway patency, tongue, swallow, chin tilt. Also report signs for long-term hypoxia. Neurological, it's a baseline cognition, strength, sensation. Important in receiving regional block, identify delirium, confusion, which may delay, postpone the surgery. Liver or renal is like not history of dysfunction, altered by drug clearance. Um, Also the lab, the CMP, like albumin, creatine, boom, electrolytes, liver, enzyme. Intergumentary assess skin integrity, hygiene, turgor, adjust dressing for fragile, like for elderly skin. Gastrointestinal, it's to document the bowel habits, sound, abdominal tenderness. The genitourinary, note urinary devices, any Foley catheters or other. Patient voids before OR entry. This is another tricky question with patient if something about voiding prior the OR. This is like, so the correct answer, patient voids before OR entry. Document urine odor, color, perineal abnormalities. Connection, there connection is like a question, we call it connection check. Which patient is at greatest anesthesia risk? So the correct answer is like, for instance, a 29-year-old female with history of stage 2 acute renal failure. And that's it for here. For patient preparation for surgical experience, we continue with laboratory assessment. So draw pre-op appointment or day of the surgery. Common labs type and screen like blood ID, bracelet for cross match, CMP, renal failure baseline, coagulation studies, clotting time, bleeding risk, CBC like hemoglobin, hematocrit, and white blood cells. That is for infection. Urine analysis, glucose, protein, ketones, infection signs, hydration. During the surgery, they will always note how much blood loss it was, and then based on that, after the procedure, we'll do another lab work and see how is the CBC. The radiological diagnostic testing, it's imaging like MRI, CT, ultrasound, X-ray as needed. Not everything needs MRI, CT, ultrasound, X-ray. Some they need CT and ultrasound, some just X-ray and CT, and so forth. The EKG for baseline cardiac assessment, ongoing monitoring as appropriate. The patient teaching reduces anxiety, improves recovery, lowers complication. So the topics is like procedure duration, expected PACU stay, when family receive update and visitation, discharge, care, instruction discussion, pre-op, while patient It's alert. Family teaching include guided to the waiting area. So yeah, the patient teaching, for instance, the nurse should discuss how long the procedure will take, how long the patient will be in the post anesthesia care unit, and when the family can expect to receive an update on the patient status and be able to see the patient. We continue with an evidence-based practice on the preoperative anxiety. Up to 60% of patients experience anxiety pre-op. Anxiety linked to increased anesthetic needs, increase in pain, increase in infection risk, delayed healing. Intervention is medication, benzodiazepines, non-pharmacological, it's aromatherapy, music, video, distraction, warming, early education. And physical preparation, we have the IV line inserted on admission, 18 gauge or a little bit bigger, preferred for blood products, so 18 gauge. Document the gauge time, date, initials, administer pre-op antibiotics. Ball and bladder prep required for abdominal, intestinal, and gynecologic or rectal surgery. May involve enema or laxative night before. Nurse confirms and document completion. The skin preparation is the purpose to prevent surgical site infection. Then patient instruction is to shower with antiseptic soap, betadine, hexachlorophene before admission. Shaving, they done only if necessary. Perform with sterile electric clippers, not razor, to avoid micro abrasions and infection. May be completed in OR after induction of anesthesia. Additional steps: remove all body piercing, remove nail polish for circulation monitoring and oxygen saturation check. Yeah, always it's a question for nail polish on the nail, the oxygen saturation gives an error. And medication for anxiety, it's benzodiazepines like diazepam, lorazepam. For nausea, vomiting history, antiemetics like Zofran. Transfer to surgical site, final responsibility of preoperative nurse. So the transfer. Confirm completion of all consent signs, history of assessment, documenting including vital signs, patient, family, learning needs addressed, skin and ball prep complete, pre-op meds administered. Then the transfer might be intraoperative nurse or anesthesia team, like per facility policy. Checklist before transfer to intraoperative care is it's the following: 1. Patient identification confirmed. 2. Physical preparation complete. 3. NPO status confirmed. 4. Medical history, admission, vital signs, labs documented. 5. Allergy bracelet visible. 6. Initial time out document. 7. Copies of documentation in file. 8. Patient education complete with return documentation understanding. 9. Patient or family questions answered. Question in the book says most appropriate response for the patient regarding the TED stocking plus SCDs. So correct answer is B. They completed each other to prevent blood from blocking up in the legs and causing a deep vein thrombosis due to your immobility during the surgery. Now on 6, we have the nursing management. Always it's nursing diagnostic problem list, fear and anxiety related to the loss of control and unknown, knowledge deficit treatment procedure, postoperative pain management needs, risk of postoperative infection, the nursing intervention. We have assessment, vital signs, oxygen saturation, establish baseline, detect abnormalities, infection, physical exam plus lab review, readiness and baseline data, oral, last oral intake and PO compliance, aspiration precaution, confirm prep, skin wash, ball prep if indicated. Action, complete pre-op checklist, remove jewelry, post aesthetics, prevent burns or injury like electrocautery, positioning risk. Inform surgical team of implants like pacemaker, central line, Mediports. Perform timeout to verify patient procedure site, ensure IV line placement. Teaching is expectation for OR experience, decrease anxiety, prevention of post-op complication, deep breathing, coughing, ambulation, leg angle, exercises, pain management strategies, non-pharmacological like heat, ice, relaxation, decrease stimuli. And then the safe pharmacological use, it's timing, adherence, addiction prevention. So, and then the evaluate outcome, the patient will be safe and surgery it's completed without any complication. Sorry it took too long. The chapter is super long. Let's review like a small preoperative phase summary. It's the preoperative nurse ensures safety education and preparation before surgery. Core responsibility is to consent, validation checklist, completion, assessment, patient advocacy, anxiety management, infection, prevention, and transfer readiness. Nursing management integrates assessment, action, and teaching to optimize surgical outcomes. So surgical categories, the chapter will have a long list about this. Elective, planned in advance, urgent, required within 24 to 48 hours, like appendectomy without rupture. Emergency, it's immediate to preserve life function. Trauma, ruptured aneurysm. The preoperative risk identification, preoperative timeframes. We talked about NPO guidelines, clear liquids, breast milk, infant formula, light meal, heavy meal. So the preoperative nurse role, verify informed consent and document, assess history, meds, allergies, anxiety, fear, virals, labs, diagnostics, perform teaching, skin prep, confirm NPO, IV access, void before sedation, remove all nail polish, jewelry, denture, contacts, communication, surgical pause data, correct patient side procedure. And we can go to learn more. We have type of surgery, like we said. They have here like emergency surgery. So the example is a ruptured appendix. Urgent surgery, it's a surgery for a bowel construction. Elective, it's knee replacement or cosmetic, so it's planned in advance. Ambulatory outpatient, patient is discharged on the same day. Cataract surgery or minor skin incision. Exploratory surgery performed to diagnose an unknown condition. Ablative surgery is removal of diseased tissue or an organ. Palliative surgery reduces symptoms but does not cure disease. Reconstructive surgery restores function or appearance, so might be breast reconstruction after mastectomy. Minimally invasive surgery uses a small incision with laparoscopic tools. Robotic surgery is performed by robotic post-atectomy, so remove something. Other types of surgeries, cosmetic and telesurgery. Surgeries are classified based on urgent and purpose. And finally, we finish the chapter.